Hello Year 3s, welcome to the Neuro revision lecture. My name is Darren. If you have any questions or complaints, please send me a message on Facebook. Let's talk about neurology. So I've tried to make this video an exam revision video. So it's good if you have some rough knowledge of the conditions on your matrix. I found that some of the revision lectures in the past were quite long, which I didn't enjoy. And I also think it's a bit dubious to have fourth years teaching third years all about a particular medical condition. So if you'd like to learn about a condition in more detail, you can check out some of the websites and resources on your screen. And I definitely do recommend learning about the conditions in depth because I find that having a good background knowledge helps you because then you can sift through all that to answer the exam questions. But for today's talk, we'll be looking at neuro on last year's exams, then going through the conditions, and finally, I will talk a bit about the topics we will go through during the live session. A really good way of learning any condition, though, is to ask your team or your reg. I did so much of my learning this way last year, and for context, I was at Dandenong Hospital. We had about 15 weeks of Gen Med, and I learnt a lot from my team and from my registrars. Our exams are kind of a simplified version of their BPT exams. So they have an incredible amount of knowledge about all the topics that we will be tested on. I also found that way of talking to someone about a condition was an interactive and enjoyable way of learning about it. You can just ask them to talk you through a condition, or you might even take a history, complete an exam, and then report back to the team, and then they may quiz you or teach you a bit about the differentials and conditions. And finally, the reason I found this so helpful is because when you ask the team about a condition, what they tell you about it, so about how it clinically presents, about the diagnosis, how it's diagnosed, about what labs you would order, and with meds, like what adverse effects you might warn someone about, the information they tell you is information that they look at or they give patients every single day. It's what they do. So I find that the information they told me was much more succinct than a web page, but also really relevant and probably what will be tested as well and what was tested as well, because the exam is meant to prepare you to become a doctor. So definitely speak to your team, speak to your reg. Any burning questions that, some questions you can't really search up online, doesn't really come up with an answer, just ask the team because that's something they will have to deal with on a daily basis. With that said, let's talk about neuro on last year's exams. So these are the statistics from last year. Don't really mean that much, but I think you can take away that neuro isn't too bad. It's easy to be bogged down in details. So where's the lesion, all the nerves, different presentations, and also stroke syndromes. But overall, it's not too bad. And now we'll go through the conditions. Exam findings I found quite helpful because they're a pretty objective measure of what's happening. I find that with symptoms, sometimes they can get a bit confusing and could be multiple diagnoses, but exam findings, upper motor neuron, lower motor neuron, and if they have something happening in the lumbar spine, they're not going to have arm weakness. So I found that the exam findings, if they give you any, are quite helpful for figuring out what's happening. Next, we have a couple questions. Just pause the video, write down what you think, or just think about your answer, and we'll go through these questions. So what is this most likely to be? Tension headache, this. GBS with Guillain-Barré syndrome, this. Cluster headache, this. Motor neuron disease, this. Myasthenia gravis. I found it really useful to learn these classic presentations of conditions because they allowed me to really visualize the condition and know what it is and who gets it. And it's also what's most likely to be on the exam as well. As we'll see later, if a condition typically presents in a certain way, that's probably the story they're going to give you on the exam because that's what is logical and makes sense. So these are actually essentially all your R3s. There's also myopathy and myelitis. I think they're more descriptive and you should be able to figure them out fine from the question. I would also learn the main treatment for each of these. So, for example, cluster headache can give oxygen therapy and triptans. But yeah, the classic presentation plus main treatment for these. Now let's talk about the rest of them. So once again, I'm not going to talk you through epidemiology, clinical features, what labs you would order. I think you can ask your team about it or just search it up. But this is how we are going to talk about it. So migraines versus stroke, intracranial hemorrhage, and head injury, epilepsy. Brain tumors will be covered more in the live session. They're mainly path or like where is the lesion, which we'll cover a bit today as well. Then bacterial versus viral meningitis, and then encephalitis, spinal cord injuries, peripheral neuropathy, dementias, multiple sclerosis, nerve entrapment, and nerve injury. All right, let's go. So have a think about it. Migraines and strokes, some of the symptoms can be a bit similar. You can get kind of weakness or unilateral weakness, particularly, and you may even get a headache with both as well. So in a question, how would you tell whether someone has a migraine or someone has a stroke? So the main two ways would be firstly age. Migraine is usually a younger person, and stroke is usually an older person, and they may have some other conditions like type 2 diabetes or high cholesterol or hypertension. And the other one is recovery. So migraines, maybe they have a history of they had it last month, or they get it, every couple of weeks for years now. Whereas a stroke, you usually have one incident, and if it's a stroke, then it will take time to rehabilitate and improve from that. And it won't be like they had so many in the past. It's a bit unlikely. So the reason I think this is useful is because in an exam, they're not going to give you a 25-year-old who has, they're unlikely to give you a 25-year-old and the presentation is stroke unless they have some other medical conditions. And a migraine, it's unlikely to be a 70-year-old and they tell you they have high cholesterol, they're on antihypertensives, and then it turns out they have a migraine. It's a bit odd for that to happen. So that can help with questions. Treatment, I think, is important as well for these. And for any treatment, I recommend you try and think about if you can come up with the treatment yourself. So think about what's wrong and think about if you had to make up treatment from scratch, what would it be? So for migraine, generally the understanding is that it's like a blood vessel issue. And then for strokes, you have ischemic strokes and hemorrhagic strokes. So ischemic stroke, what is that? Something's blocked, right? So how do we get rid of that blockage? Hemorrhagic stroke, bleeding, gushing. How do we stop that gushing? So just think about it, and I find that that helps more than just blatant memorization. So migraine, the treatment is antiemetic plus aspirin. So whenever someone feels a migraine coming on, they should take an antiemetic and aspirin. So aspirin is kind of that blood vessel effect, I'm pretty sure. Antiemetic for nausea and also keeps down the aspirin. Stroke, ischemic. So once again, blockage, how do we get rid of it? One, we can use meds, thrombolize, or we surgically take it out. And then there are some time frames they can give aspirin as well for that blood vessel antiplatelet effect. But I feel like you can come up with a lot of the treatment without memorizing it necessarily. Hemorrhagic gushing, how do we stop that? Blood pressure control. Another question they like asking for AMIs as well is, what does this person need to be on in future? So it's not like they have a stroke and then you treat the stroke and then you just send them home, no medications. They do need to be on medications. And once again, think about what type of medications might you give someone. So what are the causes of ischemic stroke? Well, literally, it's a blockage there. So how might you give meds to prevent future blockages from happening? And another cause of ischemic stroke that you might have learned about is AF. So how might you prevent clot risk or reduce clot risk in AF? I think my head's blocking it, but antiplatelets, oral anticoagulants, blood pressure control, and cholesterol control. And I feel like if you think through it, then you will be able to come up with these as well. All right, next, a little more information about stroke. So what's a TIA? I remember my ward group or my classmates, we would all be a bit confused about TIA, right? Because we kind of knew of it generally as a short stroke, but what does that mean? Whenever we took a history from a patient, they were like, oh, I had weakness for 30 minutes or something, and we thought it was a short period of time, we might consider TIA. But the actual definition of a transient ischemic attack is that it resolves by presentation, and you can't see anything on imaging. So if they still have symptoms when they're talking to you, it's not a TIA. I think that's just a clinical fact, and maybe asked in your exams as well. Next is ACA, MCA, PCA strokes. So the homunculus is one to remember. You can kind of imagine someone lying across the brain. So ACA stroke is kind of that middle part, kind of the front, and then goes across the top of your head, so lower limb. And then MCA stroke is the side, so face and upper limb. There are going to be a lot of other differences as well, and they may give you a lot of symptoms in the exam question, and a neurologist would definitely be able to tell you so many different symptoms between the two. But they're not going to give you an MCA stroke and with lower limb weakness, because that just really doesn't make sense. It wouldn't really happen. So I recommend, learning it in depth, sure, but also be very focused on what is definitely one type and what is definitely another type. PCA is occipital lobe, so oftentimes vision is affected with macular sparing, and you may also get brainstem changes as well. Next, intracranial hemorrhage and brain injury. So for intracranial hemorrhage, I definitely recommend, these three types, learning about which vessels are affected, CT scan results, and how they present. So have a think about the next two. Think about what they may be. So the first one is a subdural hemorrhage. So older person and that classic lucid interval. And the third one is a subarachnoid. You may be thinking, why do they have polycystic kidney disease? Why are they 30? Because generally these brain bleeds don't really happen to 30-year-olds. So this person probably had a berry aneurysm. And in an exam question, they would give you something. They would tell you they have polycystic kidney disease as well. They may not actually, but less likely. CT scans. I always found these hard to remember. I'd always revise them every year and then forget again long term because I didn't have a good way of remembering it. But these are what the scans look like. If you have a good way of remembering it, great. Subarachnoid I definitely knew because the blood vessels kind of go into the pia mater. So it's not like a collection. It's kind of like inside, follows kind of the vessel pathway. And in terms of which blood vessels are involved, arterial, venous for subdural. So that's kind of the slower one, which is also why you get that lucid interval as well. And then arterial for subarachnoid. Next, epilepsy. You have focal, which is starting in a specific part of the brain. You have generalized, which affects multiple areas of the brain. And generalized epilepsy, you have tonic-clonic and absent seizure. So focal treatment, carbamazepine. Tonic-clonic, you may have seen a medication called Keppra a lot. I remember I saw this a lot, and I asked Tass, who is my clinical skills tutor from last year, about this. But yeah, Keppra levetiracetam is the generic name for it. And I asked him why you see Keppra so much, because it's actually not first line if you look on ETG. Because first line is valproate. So the reason why valproate is not as common, at least at Dan Nung Hospital, is because it's very teratogenic. Which means that, so you give it in bipolar disorder in psych. You learn that, well, I learned that this year. And you don't give it to pregnant women. Like, it's just a massive no-no. And if you do give it to someone of age where they may become pregnant, then you need to also advise them to go on contraception, even like 2 types of contraception. So I think because of that, oftentimes levetiracetam is just given in hospital. Okay, next, bacterial meningitis versus viral meningitis. The main ways you'll be tested on this is differentiating between the two on lumbar puncture, and then the type of organisms, causative organism. The difference between encephalitis is encephalitis, like literally the brain's inflamed. So you get focal neurology, and whereas meningitis, you get neck stiffness, kind of headache, and more around the brain rather than like affecting the brain directly. So how do you differentiate between bacterial and viral meningitis? So have a think. The last one is leukocytes, by the way. So have a think about how you may differentiate between each of these. So for me, the main ones I looked at were glucose and protein. And I mainly focused on bacterial and viral as well. So glucose bacterial is low because the bacteria eats glucose, and the protein is high in bacterial because two reasons, I think. One is that when bacteria are bigger, so when they go into the sort of brain, they break the proteins, and so there's more protein in the blood. And also bacteria attracts more inflammatory cells and they make proteins as well, which is why protein is high. You can remember the other stuff, appearance, leukocytes, and TB and fungal, but I think bacterial and viral are the main ones. And I found it logical to remember that glucose is low in bacterial, and they're never going to give you a glucose is low and then it's a viral as well. So that's just something to keep in mind. Organisms. I'm blocking this, so you'll need to check out the slide. Actually, let's switch. Yeah, you can see the entire slide now. And sometimes they test you by not telling you the name of the organism. They just ask you what's most likely to be found, and they just describe the organism. I don't think there's a great way of remembering this except for just going through it. So this is just a list of the main ones for bacterial meningitis. The next topic is degenerative disc and joint disease of the spine and spinal cord injury. One's acute, one's more chronic. I feel like this isn't too bad. Just be mindful of, is it bilateral or unilateral, and where do the problems start? Is it from the arms down? Is it from the legs down? And that will help you localize what's happening. All right, peripheral neuropathy. I think you all know what it is. You tested in the neuro exam. What conditions may cause it? Just have a think. Main ones I could think of: diabetic neuropathy, so microvascular complication; GBS, so that progressive peripheral neuropathy; and then Charcot-Marie tooth disease, which is pretty sure it's a genetic disease. It's just one I remember. I don't think it's that relevant for assessment. Next topic, dementia. So when would you suspect that someone has dementia? So what features? Imagine you're writing a question. We've been talking a lot about what kind of a person is at risk of getting a condition, what their story or presentation may be like. So what would it be for dementia? So firstly, dementia would be an older person, 65 plus. They're not going to be 20 years old, confused, and the answer is dementia. Like that's so unlikely for them to test. And that's how you differentiate it from recreational drug use, perhaps. Next, dementia is progressive and gradual. So over months, it's not going to be someone who's perfectly fine yesterday that had a total or some kind of operation in the afternoon, and now today they are confused, walking around, aggressive. That's not going to be dementia. That's more likely to be delirium or recreational drug use or some kind of withdrawal. And the next third point is one that I found helpful, particularly this year, because we learn a bit more about dementia and depression. But how do you differentiate the two? So one way is that with MMSE tasks, people with dementia will attempt the task but not be able to do it. So they may not be able to draw the clock, or may not be able to name what you told them to remember. Whereas with depression, they don't really attempt to do it because of the energy, sort of the lower energy levels as a result of depression. And with MMSE, if they give you a score, 23 and below is indicating dementia. But beware of the possibility of depression depending on how they completed the MMSE and why they didn't do that well on it. Dementia types. Let me get rid of myself again. So frontotemporal, generally a younger person. So where I've put question marks, have a think about what other symptoms there may be. So frontotemporal, right? Think about what it's affecting. So what other symptoms may you expect there to be? Next, Lewy body dementia. You can see there's a bit of path in there as well. Vascular dementia. So why is it called vascular dementia? What might happen for this person to develop dementia? What risk factors may they have which cause them to develop this type of dementia? Alzheimer's dementia, like what do people most commonly associate with Alzheimer's? And the last one is normal pressure hydrocephalus. I learned it more this year, but it has a triad, and one of the parts is dementia. And yeah, so frontotemporal, frontal lobe, right? That kind of executive function, so behavioral changes. And vascular dementia, they probably have vascular risk factors, and the dementia worsens with each vascular incident. So they have a bleed, their cognition declines. They have a bleed, their cognition declines. It's less a kind of gradual and progressive one. It's more like step, step, step as each incident happens. Okay, have a look at this exam question and see what you think of both 68 and 69. I'll go through it now, but pause it if you want more time. So 68, 55-year-old man, no prior medical problems, 1 month history of progressive right hemiparesis, comes to emergency department because of a generalized tonic-clonic seizure. So when I think about it, 1 month, progressive seems like something's growing there rather than a stroke. Like I'm thinking stroke when you see right hemiparesis, but that's not really the story for a stroke. Generalized tonic-clonic seizure. So I think there's some kind of malignancy. I'll look at the answer options. Low-grade glioma, metastatic brain tumor, left brainstem glioma, left frontal lobe tumor. So they've told me it's right hemiparesis, so something on the left side. Probably not brainstem if you're getting tonic-clonic seizures, because that's kind of movement. And also brainstem, I would expect there to be maybe cranial nerve involvement as well. You don't really get progressive right hemiparesis. And then question 69, 25-year-old woman, 3-day history of right-sided weakness. A pretty young person, and they have 3-day history of right-sided weakness, which is kind of a medium length amount of time. Who knows what's happening? 4 years ago, she had subacute impairment of vision in the left eye that cleared up over 3 weeks. So this is a pretty classic story for multiple sclerosis. Pretty sure I've been asked this multiple times. Every time the answer is multiple sclerosis, it's always a young lady who had some kind of vision impairment in the past, which is called optic neuritis. So that is multiple sclerosis. And I think that's the main thing you need to know about it. So looking at the story, it kind of comes and goes. That's kind of the story with multiple sclerosis. Next, nerve entrapment and nerve injury. So look at this and think about what the answer may be. You may immediately dismiss this and skip to the answer, or you may think it's a really hard question, but I encourage you to have a think about the options, because I'm not extremely knowledgeable about what all the nerves do either. Or you may be, and you can do this question easily. But I'll go through the answers now. So 65-year-old woman, neck pain after lifting heavy groceries. So it gives me, I feel like something's going on here. Pain in the neck radiating the right arm to the middle finger. You find weakness of elbow extension, wrist extension, and adduction and finger extension. So basically like some elbow stuff, wrist stuff, some finger stuff. Triceps reflex is absent. So I feel like, so something's starting here leading to those symptoms. And I don't have a great idea of specific nerves, so I go to the answer options here. A, brachial plexus. Does that seem likely? Is there something wrong with the entire brachial plexus here? No, I don't think so. C5 root, C6 root, C7 root, C8 root. It doesn't sound like there's a root issue, because I feel like there would be more impairments. And also usually when I think C5, C6, C7, C8, I think dermatomes. And there's no dermatome involvement here either. Next, cerebral hemisphere, that this doesn't sound right. There's something in the brain wouldn't cause like part of your reflexes, some of your reflexes, some weakness in some movements. Wouldn't really make sense. Median nerve of the carpal tunnel. Carpal tunnel is here, so wouldn't be median nerve of the carpal tunnel. Multiple cervical nerve roots. I don't think multiple are involved. Radial nerve in the medial groove, maybe. Ulnar nerve, maybe. You can either think about, I think if you remember the hand stuff, ulnar is more medial, whereas this is sort of pain to the middle finger. And also when I think about it, radial nerve, I just remember is more sort of extension stuff. It kind of runs down the back. So I'd go with radial nerve here. If you didn't know to differentiate between the last two, you still have a 50-50 chance. So I think that goes to show you don't need to have like perfect knowledge to figure out a question. And that was sort of the point of this exam question. With that said, though, there are some nerves and MSK conditions that are useful to revise, and here they are. You can have a look. So a lot of the main parts of preclin, so median nerve, radial nerve, ulnar nerve, the particular injuries as well. So the different hand positions, same for lower limb. Quarter equina, you should know the triad there. And in general, like with solving questions, I recommend thinking logically about how big the injury is. Like, is it the whole right side of the body is knocked out? Is it one particular movement of their pinky finger? I feel like that can help you narrow down the answers. And then also, is there sensory involvement? That can be really helpful with knowing if there are multiple nerves involved or multiple nerves involved, or where the lesion may be in the brain as well. All right, so we've reached the end of this video. 26 minutes, I think that's okay. Not too bad for neuro. But in the live session, I think we're going through questions essentially. So these topics, among others, will be covered. So nerve injuries, more path. I didn't talk about too much path today. I don't think it played a big part in our exam, but we'll be talking about path and brain tumors, like I mentioned earlier, neuro exam findings, and also some of the conditions we talked about today as well. All right, thank you guys for watching this video, and I'll see you in the live session.